want to talk about is when you specifically focus on let's say populations of color and start looking at different ethnic groups, and let's if we were to focus on that just specifically as a health disparity group, then you start thinking about trust issues, specifically between certain groups and academia, certain groups and the industry, certain groups and even nonprofits. As a nonprofit, I can tell you that I cannot go into a community, whether it's a population of color, whether it's an urban-based community, and say, you know, you have health disparities, and therefore, I think these are the things you should do. You should enroll in clinical trials, you should do this, you should do that. That's never going to be accomplished, and it seems like there's some type of disconnect between the accrual process that we're trying to achieve and the initiative of actually going in there and educating or creating awareness or doing outreach activities. So there's a challenge of how do you bridge that gap? How do you address those very sensitive issues? Is there a trust issue? We all know there's been certain things in this state that have reduced some trust issues between some tribes, the government, some tribes, and academia, and et cetera. I mean, we've had conversations specifically about those issues in the past, and have had conferences like this addressing issues like that they're very sensitive, they're very challenging, they're very difficult to overcome. But increasing and creating and starting the discussion is the most important thing to hopefully reducing cancer disparities in some of these populations.
Not sure that everyone knows, but if you're involved in federally funded cancer research, the federal government requires that we keep track of the populations we serve, and they document very closely. And Mayo Clinic's had a challenge in serving underserved populations, as other people have. And it's something that's important to us, not only because it impacts our federal funding, but because we want to be good members of the community. And I think that there's so many issues involved that you have to look at them individually. But one thing I think that Mayo Clinic's done that I think has been effective is decided to fund an oncologist from Mayo Clinic to staff the oncology clinic at the Lima Indian Medical Center. And by going there and serving the patients, then refers those where it's appropriate for clinical trials at Mayo. And so not only providing clinical care, but then access to clinical trials.
It's a real challenge. One must keep in mind that the incidence of multiple myeloma, the frequency of multiple myeloma, is twice as high in the African American population as it is in Caucasians. And it's well to keep in mind that when the large national cooperative groups, the SWOG, the Southwestern Oncology Group, Eastern Cooperative Oncology Group, when the African American patient is admitted to a trial, that the outcome in that patient is the same as in Caucasians. So it's not the disease per se, it's probably the treatment and so forth that the African American has that might well shorten survival.
Comments or questions out in the audience?
My question is more of a policy issue question or a legislative question. I mean, it's fine to say that we want to put the poor on clinical trials and et cetera, but it still comes down to, I mean, I don't know that there's any free clinical trials out there. So how does some insurance companies may not pay for a person on a clinical trial until they're in a clinical trial phase 3 or 4, for example. So that may eliminate those individuals from being on a phase 1 or 2. So what can we do for Arizona to mandate insurance coverage so that it's covered all the way through? or access or
I
state.
think you just stumped our panel. I need any ideas.
Let's jump in.
I think it's phase 4. I mean, yeah, so it's, what do you do?
Well, one thing that I think, and it doesn't deal with the insurance aspect of this at all, but I used to actually work with quite more underserved population than what I have here. Now I work at Mayo Clinic, and I worked in rural Michigan, and I worked with veterans that lived hours away. And some of just the most simple grassroots things, like sending vans up to pick these people up, were the biggest things that got people involved in clinical trials. If you have an elderly person without a working vehicle that's 4 hours from your clinic, they may want to do it, but that's just not going to be their reality unless you provide those really basic things. So I think that was the biggest thing that improved our participation in research.
Yeah, just the practical, everyday issues that people deal with.
Thank you, Angela. Angela will be presenting tomorrow at our conference, and she will be talking about her work with people on clinical trials. I think some of the issues that we're bringing up are, again, some of them are so incredibly practical, just what Angela just said, that it's not necessarily the particular color, size, shape of the person or the clinical trial, but something so practical. And I'm going to kind of pass the microphone over to someone who works on the Navajo Reservation where we're currently working, because again, I think those are the very challenges that Michelle faces and that are being faced in a lot of rural communities, beyond a particular population. So, if you don't mind, Michelle, I'll put you on the spot. Yeah.
Always.
I do that all the time, so.
My name is Michelle Morgan Flowers. I'm the utilization discharge planner for the Ft.defiance Indian Hospital. I'm originally from Kentucky. We moved to the reservation. My husband and I are both nurses. We have 2 children there. I've been there on the reservation for 13 years. I started working in the emergency room and then moved to pediatrics and ran the pediatric clinic for 6 years. Also worked on the pediatric med surge and case manager for surgery clinic. I started the case management about 4 years ago and then started tracking our cancer patients. And I was seeing a big hole on how we report our cancer patients and who was tracking them. I went to the utilization department 2 years ago, and I continued tracking that as my extra project. And I met Barbara 3 years ago through Fred Hubbard. So we've been working with Barbara trying to track our patients. I have 550 cancer patients right at Ft.defiance right now that come across my desk. 137 of those are dead. We're seeing patients come through at stage 3s and 4s. We're traveling 2.5 hours to UNM to Albuquerque, or 3 hours to Flagstaff, or 4.5 hours to a lot of our patients don't have electricity, do not have water, still use outhouses. They still speak Navajo. We're working with the Dene College, and we want to thank Mayo for providing funding to do a translation for cancer translation that just came out to publication about a month ago, and we're trying to introduce that. They printed up 1,000 copies of the Navajo translation. So we're hoping by awareness that we'll be able to get to